Yep. A couple more seconds.
Wasn't sure what time zone. I never know what time zone everyone is when we do these different talks. So
yeah, I mean,
cool.
We're all over the country, but I am in New York. Okay, so we are good. Hello, web shadowers, and welcome back. This is our fourth session for fall 2021, and we would like to thank you for joining us this afternoon. Today, we have the pleasure of hosting Dr. Gerardo, who will be teaching us about general surgery. As always, please remember that the Google form will be posted in the chat and in the description of this video when the session is over. With that being said, Dr. Gerardo, you can start whenever you're ready.
Hi, everybody. Thank you again, so much for having me. I think this is a great format for a lot of students out there who don't get the opportunity to, get to shadow physicians in person, especially with the COVID pandemic and everything. So I want to thank you guys for having me. I'll start. Let me start sharing my screen here. Okay. So my name is Gerardo. I'm a general surgery resident. I am a resident at Wright State University, which is a program in Southwest Ohio. And I'm currently doing my dedicated research years with Cincinnati Children's Hospital Medical Center with their Department of General and Thoracic Pediatric Surgery. So the objectives, we're going to talk about kind of my path and potential future paths that you could take as a general surgery trainee. I'm going to talk about my typical day as a general surgery resident. And then I have a few cases at the end to sort of try to emulate, what it would be like if you were to actually shadow me in real life, and maybe we would see some patients. So first, about myself, why I chose general surgery. I have two sort of, well, I have a million reasons, but two main reasons that I'll touch on. The first is that in a previous life, I was a musician. I used to play all sorts of different instruments. When I was a medical student and I got a chance to rotate on my surgery rotations, it just felt very natural to me to get to use my hands again. Obviously with a different purpose, this time using my hands and technical skills to take care of a patient. It just felt like a lot more natural of a form of practice for myself because of that, because I'm so used to, using my hands and worrying about, how you're holding a certain tool or something like that. There are a lot of analogies there with using musical instruments. The second main reason that I chose general surgery is, for me, I have a terrible attention span. So for me, I really appreciate the instant gratification of, a patient comes in and they have a gallbladder problem. Then we cut out their gallbladder and then they're eating ice cream and they're out of there. That kind of that premise that there's a problem, we cut it out of their body and then they're better. I really like that. So those are the two main reasons for me. And then once you guys, whatever stage you are in your education, you really learn about what you do and you don't like when you get into it. So, as much as you may think that you want to be, a surgeon, maybe when you get to the trauma bay, you find out that you don't like it so much. And conversely, if you're like me, if you think you're going to be a pediatrician, you get to the trauma bay and you realize, oh, I'm not a pediatrician. I really love surgery. So as much as you think you might like something, I say keep an open mind. Once you get there, you might learn something about yourself and what you want to do with your career. The pathway to general surgery, at least in the United States, I know we have a lot of followers probably all over the world, I imagine, with this group. The pathway in the United States is pretty laid out, somewhat rigid, I would argue. You do after you complete high school education, then you move on to 4 years of college. You probably major in a science or something else, psychology or something like that. You probably are trying to juggle research projects, extracurricular activities, keeping good grades. You have to take what we call the MCAT in college, the medical college admissions test. And my advice for any of you out there who are pre-med is apply early, as soon as you can, because medical schools in the United States are rolling admission. So the sooner you get your application in, the sooner that a school is going to read your application. Then once you get to medical school, once you're accepted, yay, congrats. The format for medical school is also kind of rigid as well, or at least it has been for the past over 100 years in the United States. The first 2 years of medical school are didactic education. You're in a classroom, you're sitting there, death by PowerPoint. And then the second 2 years are clinical years. That's when you go and you do your rotations in various specialties and you figure out what, you want to specialize in yourself. And then at the same time, you can do electives. So if you're interested in some subspecialty of some sort, you can work that in, usually your third and fourth year. And then at the same time, kind of like in college, you're juggling stuff, extracurricular activities, trying to do volunteer work, trying to do research projects and potentially present your posters at conferences and things. And then, of course, trying to maintain good grades at the same time. Instead of an MCAT, what we take in medical school are what we call STEP scores. So these are kind of like your USMLE. They're kind of like the national medical training exams that every medical student in the United States takes. And those, are moving towards pass-fail. So whether or not they have an impact these days on, or at least especially for this group, whenever you guys are in medical school, how much they have an impact on, how competitive you are, who's to say? But if you're the typical, pre-med student, you're probably the type of person who is trying to ace every exam that gets thrown in front of you. And then in fourth year, you could go off and do away rotations, rotating at different hospitals to try and either audition, they call it audition rotations, where you rotate with a program that maybe you're interested in applying to, or just programs that you're curious about and you want to try some different things. Then once you get into general surgery residency, through the match process, which is an algorithm-based computer system where you interview at all these residencies, you put in order, rank order 1 through whatever, 12, however many you interview at, the order in which you would like to be, your favorite to least favorite. Those residency programs rank all of their applicants similarly from their favorites to their least favorites. And then the computer algorithm called the match puts everyone together with the best possible outcome. So then once you get, matched into a general surgery residency, again, in the United States, it's fairly rigid. It's fairly structured, at least 5 years of general surgery residency, because it requires 5 years of clinical training. Most programs have an option to go off to do research. A lot of academic programs have it built into their residency training, where you do 1 to 2 years of dedicated research, or more if you would like. Instead of, there's always a test in each of these stages. So in general surgery residency, it's called the ABSITE, or the American Board of Surgery in-service training exam. Every general surgery resident in the United States has to take this every year. Same thing. It's kind of one of those things where, it may or may not have a bearing on whether or not you go on to a specific fellowship or something like that. We have also exams that are more physical, because it is surgery is a technical sport. So FLS, or fundamentals of laparoscopic surgery, we have to take a test where we do different almost like challenges with laparoscopic tools, and someone watches us and grades us on it. Similarly, FES, fundamentals of endoscopic surgery. It's basically using a colonoscope or an endoscope, and they have, again, like a computer type program that simulates that, and you have to complete certain tasks to get a certain score to say you're allowed to do endoscopy. And then at the completion of that, you have board exams. For general surgery, there's one written, and then there's one oral exam where you dress up in a suit, and it's at some hotel and you go into each room and there's an examiner there and they will give you a clinical scenario and you have to talk through what you're going to do for that patient, and they'll give you questions and stuff like that. So all sorts of tests. And then after that, then you got to do your, to maintain general surgery practice afterwards, then you have to take, your board exams every 10 years. All right. So general surgery is kind of like one of those specialties where there are a million offshoots from that. So once you are a general surgeon, you can go off and do all these different types of subspecialty training. Here's a list that's probably not even comprehensive that I pulled from, I think this is from the American College of Surgeons website, but you could see anywhere from being a breast surgeon to being a heart and lung surgeon to, complex transplant surgery or vascular surgery. There's all sorts of different subspecialties that you can go off and do a fellowship for. So after that residency, you can go off and do 1, 2, 3 years of fellowship training and become, very subspecialty trained. Now, the cool thing about general surgery is that you pretty much learn how to operate everywhere in the body. I usually tell students on general surgery, you're going to learn how to operate on basically everything except for the brain, probably the eyeball and the ear, and then bones. But even sometimes some bone stuff general surgeons do. So you're going to learn how to operate everywhere in the body, pretty much every organ system. Now we do mostly focus with stuff in the chest and the belly. But, if you think of something else, like, for example, vascular surgery, you got blood vessels everywhere. You're going to be somewhat operating everywhere for that. So a lot of different potential, if you have a certain organ system that's your favorite, there's a potential to go do a fellowship in that organ system if you branch off from general surgery. And then, once you're out in practice, then the options of what kind of surgeon do you want to be? Do you want to be an academic surgeon? Do you want to be a community surgeon? Do you want to be someone publishing or presenting at conferences and doing research? Do you want to be someone who's just, day in, day out operating, and you're just a machine? You're, a skilled technician, so to speak. A lot of different options. Now, as a general surgery resident, the typical day for a clinical general surgery resident is kind of like this. So you're gonna, show up at the hospital, usually, I don't know, somewhere between 5 and 6 or something like that. Usually, then you're gonna hear about what happened overnight from the night resident who was covering or whoever was on call. You're gonna pre-round chart check your patients. You're going to run the list, which means that you basically, with your team of residents for that particular service, whether it's, if you're on transplant or vascular or cardiothoracic or whatever you're on, you're going to run the list. You're going to go through each patient and talk about what happened overnight, how they're doing right now, and your plan for the day. And then usually operating rooms are going to start their first case around 7 to 7:30. So you're going to be in the OR in the morning. Hopefully time to get lunch somewhere around noon, rounding somewhere around that time with attendings, maybe between cases, or sometimes they have scheduled times. They have blocked off time where they can round, meaning you're walking around the hospital, going into patient rooms and seeing how they're doing and talking to them and, examining surgical sites or anything that you need to do for that day. The afternoon is usually a mix of things depending on what level of resident you are. If you're an intern, you're probably, going nuts, writing down notes, orders, taking consults, things like that. Sign out is usually somewhere around 6. So it's kind of like a 12-hour, sort of like a 12-hour shift, I suppose. Sign out meaning you kind of tell the night residents or whoever's on call about whatever you did for that day and what to look out for at night. Kind of handing off the duties so that they can take over for your service. And then usually if you have notes to finish up, orders to finish up, or something, that you got to finish before you go, usually get out of the hospital around 7 or so. So that's like a typical day. A lot of variation there. Some days things get hectic and, you stay later than 7. Some days things aren't really going on and, you'll have people out before 6. Depending on the residents that are there, the cases that you have going. And then sometimes on the weekends, for example. Every program is a little bit different. You might just come in and round on a Saturday and then hand it off to whoever's on call for the weekend. A lot of variability, but this is basically what it's like 6 days a week for a general surgery resident. Somewhere in between there, you got to do your own stuff, exercise, grocery shop, do laundry, take care of a family if you have a family, things like that. The cap, they say, per the American College of Graduate Medical Education, which is the governing body of residency programs, the cap is 80 hours a week. That's the average over a 4-week period that you're allowed to work. I would argue that general surgery is one of the residencies where you're probably going to be close to 80, for most of your residency. All right. Before we get into the case, were there questions or anything that we want to jump into? Or I know we're live on YouTube. Oh, I see this question. Do you feel as though you have an adequate amount of personal time throughout the week? Kind of depends on the service, and it depends on your own personal, what's personal time to you. So when I was an intern, we had our first kid. My first daughter was born, and honestly, it's like I feel like there's never enough time. If I could have been I could have been working a business job at 40 hours a week, and I doubt I would feel like it was enough time to be with my daughter. So it kind of depends. Now, that being said, before I had a kid, and it was just the two of us and our dogs, like I was so invested in, I still am. I mean, you're just so focused and invested in surgical training that I was just eat, breathe, sleep, surgery residency. Some people still do that. It's just making time for yourself, whether it's, I need to go on a 30-minute run every other day or whatever you're doing, or raising a family, or maybe you have other hobbies, like you play music or something like that. I mean, a lot of residents, I've seen residents do all sorts of things. Some of them train for triathlons while they're in their training. So it's really, and some of them raise more kids than I have. Some of my co-residents have like 4 kids and stuff like that. So, I mean, it's really about yourself and what you think you have enough time for. I think a work-life balance is important, obviously, for your own mental well-being. I feel like I am balancing that now, but I'm a research resident, so I'm only working like 40 hours a week right now doing research. But, from the clinical side, it's really kind of varies based on the person. But yeah, I would say there are times where I did have enough personal time, times where I didn't. Kind of goes up and down. And then what do you feel is the toughest part of general surgery? Probably the time demand. If I had to say one thing, because that kind of bleeds into everything else. The time demand means, like, obviously you are exhausting yourself physically, but then also mentally and stuff like that. To work 80 hours a week, 6 days a week, is a lot for anybody. It takes a lot of grit, I think, to be a general surgery resident. I think a lot of times general surgery residents get a bad rap for being a little grumpy, but when you are a resident and you have that interaction, cut them some slack, because they might be close to or over that 80 hours for that particular week. So, some people just have it harder than others, but the time thing kind of bleeds into other things, because then, if you're working too much, you don't have time to study. And then it's kind of like, oh, studying is the hard thing, or you're working too much and you don't have time to take care of, your house duties, whatever that is, and the laundry's piling up, things like that. So really the main thing that I would say I would advise people, and I think that I've gotten better at, and I'm still getting better at, is time management, especially if you have a partner of some sort, having a shared calendar and making sure that everyone's on the same page. There's definitely the time issue bleeds into other issues with just life, not just work, just life. So that's probably the toughest part. So time management is important. Last one for now. Do you have an opinion regarding PA versus ND? I don't know if there is a versus. I feel like if they're two different. So in the medical field, I feel like it's a team thing. Every team is composed of multiple different people with different levels of training, different expertise, different capabilities. And when you have it, I've worked on teams that work really well with PAs. But, you know, for the most part, the structure of a team is going to be something where it's like, you know, at least in general surgery residency, it's going to be some general surgery residents. Maybe there's PAs or NPs on the team as well. But, you know, the team is led by the attending, who's an MD or a DO. So it's really just depends on, you know, your personal goals and what you want to do with your life and how you want to spend your training and what level of, you know, practice you are trying to get to. You know, if you want to be that attending, if you want to be that surgeon that's calling the shots, you kind of have to be, you know, an MD or a DO. But the PAs and the NPs are like very critical parts of the team. You know, a lot of times they're the ones on the ground, you know, really running the service for the attending. So if that's something that you're interested in, then become a PA, become an NP. At least in general surgery, that's how I've seen it. You know, PAs and NPs can't really practice general surgery on their own. I know it varies depending on specialty and state and things like that, but I don't think that you can just, you know, go get your gallbladder taken out by a PA these days in the United States. That being said, you could be a very helpful part of the team as a PA on a surgical team. So I don't know. It's kind of based on you got, and obviously, you know, the student loan debt and the time debt that goes into becoming an MD or a DO is substantially greater than the training involved with becoming a PA or an NP. So that's another thing to consider. You know, my friends who are PAs did a lot less training and, you know, make a lot more money than I do right now. So it's totally just whatever you guys, you know, are comfortable with, interested in, what you want to do and get out of with your career and your own education. So I don't think it's a versus. I think it's like you know, it's a team and you just got to pick which position you want. All right, let's do a case. So let's say you are working with me on, because I'm a research resident at Cincinnati Children's. Let's say we're at the Children's Hospital, the local Children's Hospital, and this kid comes in. He's a 9-year-old male. He has acute onset right lower quadrant pain. That's all the information we get on the consult page or whatever it is. So then I'm going to look to you guys and I'm going to say, well, what do you want to do? So go ahead and type in the chat box. I'm going to say, go talk to the kid. What kind of questions are you going to ask? What kind of things are you going to have in your mind? What kind of questions would you start to think of for this 9-year-old kid? He's got pain in his right lower quadrant. I'll give you guys a minute to think about it, kind of type some thoughts in the chat box here. All right, so hopefully you guys have thought of a few things, but this is basically what we want to do, what a history and physical. So we want to find out about that pain. How bad is that pain? And some would argue, you know, pain is kind of like the, what do they call it? The fifth vital sign or something like that, but it's kind of subjective. So you got to give them a scale. So you say, how bad is it? 1 out of 10, you know, let's say this kid, he's at an 8 out of 10. Then you got to ask him, when did it start? Well, for him, it started about 8 hours ago before he got to the hospital. It started at his belly button and it moved down to his right lower quadrant. And then the next thing that we do as general surgery residents, we do this pretty much on every patient, you got to push on their abdomen. So we do an abdominal exam. He's significantly tender to palpation in the right lower quadrant. Okay. And it's so bad that when you push on the left side, he hurts on the right side. That's kind of weird. All his vital signs are normal. That's like blood pressure, heart rate, respiratory rate, how well he's breathing, and his oxygen saturation. They're all normal. His temperature, it's normal. All right, so the next thing, we got to make a differential diagnosis. So I see that some people are saying appendicitis. That's a good thought. When I tell students to think about a differential diagnosis, especially in surgery, the easiest first thing to do is think about your anatomy. So if we divide the abdomen into 4 quadrants, he had pain in the blue part, his right lower quadrant. So then you got to think what's in the right lower quadrant? Well, your appendix is there. If it's a female patient, then you have to think there are gynecological things there. There's a fallopian tube, there's an ovary. If it is, a bulge or something in his groin, then you can think, well, it could be an inguinal hernia. And then similarly, you kind of move that around the whole abdomen, and you think about, the green part. If someone has pain in that left upper quadrant or kind of like the middle, that's where your stomach is. So you got to kind of think, especially in surgery, anatomy first. Anatomy is king. Know your anatomy, and then you can kind of do a lot from there. Okay. So we move on and we get some lab work, some blood work. We get some imaging for this patient. We're going to get an ultrasound of his abdomen, and the ultrasound's shown here. And the radiologist kind of did us a favor here. They measured the appendix, and they're showing us that it's dilated. They're showing us that the wall is kind of thick. It looks kind of angry. And then we get some blood work, and we get a complete blood count. That's what CBC stands for. His white blood cells are 17,000, which is a little bit elevated. His hemoglobin's okay. His platelets are okay. So he has likely appendicitis. So a lot of you guys were right. Now, appendicitis is the most common surgery that pediatric surgeons perform. And we treat that minimally invasive with what we call laparoscopic appendectomy. Laparoscopic meaning we use these tiny little sticks with tools on them, make little punch hole incisions that are maybe half a centimeter or a centimeter long. And then we go in with a camera and we operate just with those little tiny stab wounds. This is what that looks like in real life. Now, this isn't an appendectomy. This is some more, I don't know what this is, but this is a much more complex surgery, as you can see with all the different tools that they have. If you were to do a laparoscopic appendectomy, this is the view that you would get from the camera. So you're looking at that worm-like structure there with the angry blood vessels. That's the appendix. It's really big and dilated and angry, and it's coming off of the colon there. You can see they're holding it up. If you trace it back kind of to the right there, it's attaching into the cecum, the first part of the colon there. So what we do is we basically cut that appendix off, cut off the blood supply, put that appendix in a little baggie and take it out of the belly. And then we're out of there. Now, to recap, like I said, the appendectomy is the most common procedure that pediatric surgeons perform. When we did imaging, so here on this patient, we did an ultrasound, but in adults, oftentimes you're going to get a CT scan. The reason we don't do the CT scan in all the kids is because the radiation exposure, we don't want to expose, growing children to all that radiation that they get from a CAT scan. And then kind of nuanced things to talk about. There's some new literature out there to support the use of just antibiotics and non-operative treatment for some patients who have appendicitis. They seems like, especially in kids, you might be okay with just doing antibiotics if it's not severe, like complicated appendicitis, which is definitely relevant in the time of COVID when resources are limited and hospitals are, overly booked. The other argument is if a kid comes in, they need their appendix out, you can get them in and out without taking up a hospital bed, because you could do that within, get them in and out of the hospital within like 8 hours or something like that. Have them eating ice cream on their way out. So some other things to consider. Now, this is what a CAT scan looks like. I call it the donut of truth. So it's going to take almost like a whole bunch of x-rays, slice the kind of like x-rays. It's similar radiation, but not quite. It takes all these x-rays and kind of turns the person into like sliced bread. So you could see them in different cuts, what we call them, different levels of their body based on where you're imaging it. So it takes all these different slices, and you can look at the bread and kind of see what's inside and kind of see how their appendix looks. Now, this is the ultrasound. Now, a lot of you guys are pre-med people, I know. So the ultrasound, if you guys are in physics, the way it works is there's crystals at the receiver there, the sender and the receiver. They vibrate at a certain wavelength that sends sound waves down, then will hit different objects of different density that then gets reflected back, and then the receiver will get those reflected waves and tell you the different densities and put them in a grayscale image that we see as an ultrasound. So that's kind of how the ultrasound works. So no radiation. All right, we'll keep going here. The second case. So now we finished that surgery, and now we're hanging out, and we're also on call for some level 1 trauma center as well. So this is a really busy day. So we're trying to grab a snack, and then suddenly out of nowhere we get a page comes in, and this is all it says: 24-year-old male, category 1 trauma, right upper extremity, gunshot wound. That's what all this word alphabet soup means. His heart rate is 120, which is a little fast. His blood pressure is 100/60, which is a little low, could be a little bit normal. His oxygen saturation is fine at 98. He's on 2 liters nasal cannula, and there's a tourniquet in place. So there's a lot of information you can get from these very few letters. I mean, this is like a fraction of a tweet, right? So we could tell a few things. We could tell the age of the patient, which tells us a lot about their physiology. We could tell that this is a category 1 trauma. So at different hospitals, when the trauma comes in, they have it broken down by severity, category 1 being the most severe, category 2 meaning it's less severe, less life-threatening, I suppose. He has a gunshot wound. GSW is a gunshot wound. He got shot in his arm, and it's so bad that he has a tourniquet in place. We use those to stop bleeding. Now, despite the tourniquet being in place, his heart rate is still a little bit fast, and his blood pressure is low, which makes me think, could he have bled out too much, that now his heart is trying to compensate for a lower volume of blood? So it's beating faster to try and perfuse his organs and his brain. Could be. Now, when the trauma comes in, this is kind of what it looks like. You got a guy, well, a person, I suppose, on a backboard, and a whole team that kind of moves him over. So the ones that are in the blue are obviously the trauma team. The ones that are in the shirts there, those are the EMS, the first responders who brought the person to the hospital, whether it's from a helicopter or from an ambulance. They transfer the patient over to the bed, and then immediately the team is going to do what we call the ABCs of trauma. Now, this is what we call the primary survey. This is what every trauma patient is supposed to receive. Trauma surgery is very algorithmic. There's a lot of good data behind how we treat trauma patients. So this is kind of the breakdown. A, which is the airway, and basically whether or not their airway is patent, meaning do they need to be intubated? Are they able to move air from their mouth down to their lungs? So basically, is their trachea intact enough that they can move air on their own? Because if they can't, that's probably the first thing that's going to kill them. So while you're maintaining cervical spine protection, meaning the bones in their neck, you're going to check if they have a patent airway. Oftentimes, if they can talk, that's kind of the rule of thumb. If they can talk, then they probably have a patent airway. If they don't, do you have to intubate them, meaning putting a breathing tube down their trachea to ventilate their lungs for them? B stands for breathing. So you listen to their lungs on both sides. So there still is some use for a stethoscope if you're a surgeon. And then C is circulation. So you're evaluating their heart rate and their blood pressure. If they need to get fluids or blood, then you have to get intravenous access, and controlling hemorrhage. So in this patient specifically, trying to keep them from bleeding. And then B is disability. You do a quick it's kind of a proxy neuro exam called the Glasgow Coma Scale. It's kind of a predictive measure to see how someone's going to do, and especially a situation like this, like a trauma. And it looks at their eyes, their movement, their arms and their legs, and then verbal. So how well they're able to speak. From that score, you can kind of predict how they're going to do. E is environment. So we're kind of getting into the weeds here. A, B, C, D, E. So environment, meaning we're going to have to remove all the clothing of this patient and examine the patient in their entirety, especially if it's something like, think if it's a gunshot wound, how do you know there's only one? If they were in a car crash, how do you know all their injuries, scrapes, bruises, cuts, things like that, unless you examine them in their entirety? So that's kind of E. All right. So we do all this ABCDEs and we look at the guy's arm and here's what we see, this big bullet wound in their arm. Holy cow. Well, let's take down the tourniquet, huh? Oh my gosh, there's some more blood just oozing out, bright red blood. It came out so fast it sprayed the wall. Holy cow, it's pulsating. Well, that makes me think that this is probably an arterial bleed in this person's arm because there's enough pressure behind it to shoot it back, and it's bright red oxygenated blood. So this guy probably has an arterial injury as opposed to, you guessed it, a venous injury. That would be dark red blood. It would probably kind of slowly ooze out or quickly ooze out, but it wouldn't be pulsatile. It wouldn't be in line with, you look at the monitor and it's going with this heart rate or something like that. So arterial bleeds concerning because patients can, depending on which artery is damaged, they could bleed out. They could what we call exsanguinate. They could pass away. So what do we do next? Well, this is a general surgery talk. So guess what? We're going to go to the OR. Now, this is, let's say if there was a gunshot wound to his arm, this is probably the culprit, the brachial artery, which is kind of, you can feel it in between your biceps here. If everyone kind of pulls up your arm under your bicep muscle, you can push in and you can feel your pulse there. That is your brachial artery. If this guy got shot in his arm, it went right through his bicep. Maybe he damaged that and that's what's bleeding out. This is a really pretty picture. This is probably from a vascular surgery where they're doing like a, I don't know, like a, what do you call it? They're for dialysis. They're trying to make a fistula or something like that for dialysis. This is a really pretty dissection. This is probably not what it looks like in a gunshot wound, but let's say hypothetically for this guy, you go in there, you find the brachial artery and it's transected. So you can repair that. Depending on how it looks, you could, if you can bring it together, you could sew those two ends of the artery together, what we call primarily, meaning you just sew them together, or what would probably be more realistic is either a bypass with, you could use a vein for that, or what we call PTFE, polytetrafluoroethylene. Don't quote me on that. It's basically like Teflon, but it's a synthetic material that is it's like a substitute for artery if you have to do a bypass, or you can do a patch. The patch could also be PTFE, or it could be bovine pericardium or a cow's pericardium, the covering of their heart. They kind of turn that into a product that you can use as a to do a patch, what we call angioplasty. So depending on the damage, you could repair it right then and there, restore blood flow to the rest of his hand so he doesn't lose his hand, and then kind of close it up so that he doesn't bleed out. Okay, cool. We saved his life. Hopefully we're doing okay with time here. I know it's 12:40, but just holler at me if we're getting close or anything like that, or you want to move on, or there's a buildup of questions, feel free to throw them in the chat here. But we can move on with the next case here. So now we're going to change gears. We're not on call anymore. Now we're in clinic. Okay. We're in the surgical oncology clinic. Okay. So we went from ped surg to trauma to now surgical oncology. General surgery is a very diverse field. So, and then you get this guy coming in for his visit. And first thing that we do is we go in and we talk to the guy. Well, he's really nice. Appears like he's doing well. NAD means no acute distress. We're in clinic, so he's just kind of chill. He just drove here. But he noticed some blood in his stool for the past 3 months. It's been on and off. He doesn't have any abdominal pain. So his family medicine doctor had some concerns and decided, hey, maybe you should go see the general surgeon. Okay. So on exam, his heart rate is regular rate and rhythm, no murmurs, rubs, or gallops. You listen to his lungs. They're clear to auscultation bilaterally. His abdomen, because like I said before, we push on everybody's belly, his abdomen's soft, non-tender to palpation. His vital signs are within normal limits, but he's having blood from his rectum. So you guessed it, we have to do a rectal exam. We do it and there's no gross blood, meaning that there's no blood visible on your glove when you take it out. You could also do a hemoccult test, which is kind of where you smear the stool onto a piece of paper. It changes color based on whether or not there's blood present, like microscopic blood present Let's say you do that and also there's nothing. So you got this guy who is bleeding on and off from his rectum, but he's pretty much like okay right now in the room. So some other things that you want to ask about his family history, whether or not he's had a colonoscopy. And, think to yourselves as you're watching this, when are people supposed to get colonoscopies? What age? And when would you be concerned about someone that you would tell them to get a colonoscopy? Maybe any budding GI docs in the room here. Did this guy get any previous colonoscopies? If they are, could we look at the photos? Could we get the notes, the records from the gastroenterologist? Why did he get colonoscopies in the past? Did he have this bleeding before, or was it just regular screening? And then you got to ask about the other stuff, which as a general surgery resident, we're very comfortable asking. Is he constipated? Does he have diarrhea? Ask about his poop. Is it blood mixed in with the poop, or is it at the end of his bowel movement and it's just on the toilet paper? Those kinds of things are important to note. Is it painful when he poops? Things like that. Those kind of help us with the next part, which is making our differential diagnosis, right? So when it comes to blood in the stool, there are so many different reasons that a person could have blood in their stool. I listed a few here. And then I also put in that picture of the colon, which as a general surgeon, we operate on the colon a lot, I would argue. But our differential diagnosis, by and large, the most common stuff is going to be non-scary stuff. Anal fissures, which means a tear in the anus. Either someone who's too constipated, their bowel movements are too hard, oftentimes we see this in kids and things like that who maybe don't drink enough water, or they are kind of, what's the word for it? It's like, poop shy, where they, you go to camp or you go on vacation and you don't poop for a while because you're having too much fun, or you don't want to, or things like that. And your poop gets too hard, you get constipated, and then it can tear your anus. Well, that is a very common reason for anal bleeding, rectal bleeding. Hemorrhoids, also very common, not so much in kids, but more so in older patients. The fact of the matter is that the veins that are in the rectum or around close to the anus there, if you sit on the toilet too long, you're scrolling through TikTok too long, or you're constipated and you're putting a whole lot of pressure when you're, trying to have a bowel movement, those veins can get a little bit too big, too dilated. And over time, those dilations can get so big that you get hemorrhoids. So they're kind of like internal veins sticking out into the lumen of the colon, or the rectum. Those can be anywhere from, little tiny ones that are bleeding a little bit to large ones that are so big that they're actually sticking out of the anus. You could have an arterial venous malformation, or an AVM. Those are common. Those can bleed a lot. You could find those on a colonoscopy and, zap them with some cautery or something. Diverticulitis, also very common, especially in older patients. So basically, if you look at this colon and you see those little, kind of like how it's like pouches, kind of like indentations. Well, there are arteries throughout the colon here. And at those little break points of weakness, they could herniate out. So kind of the opposite of what the hemorrhoid was, it would stick out of the lumen of the colon, and you get these little pockets almost. Okay. So that's diverticula. If they get infected, that's diverticulitis, and then those can bleed. And then, of course, the one thing that you got to keep in mind, especially for a patient like this, who's older and has painless bleeding from his rectum, you have to think colon cancer. All right, so I know that all of you were thinking about this, but these were the guidelines. Now, this is probably going to change. I don't know if it's official yet, but this is the USPSTF, the United States Preventative Task Force, something like that. Don't quote me on that either. But this is basically the federal body that kind of puts the recommendations for things like screening and things like that. So for this one, for the prevention of disease specifically, for this one, the rule of thumb is kind of to say patients who are 50 to 75 should get a screening colonoscopy by the age of 50. And then depending on those findings, that will determine how frequently you get a colonoscopy between those ages of 50 and 75. Now, this is kind of changing. There's some talk of it going lower to 45 to start. And then if you have family history of specific colon cancers and, genetic diseases and things like that that are associated with colon cancer, then the number kind of gets lower and lower and lower. And then I've also heard arguments of like, should we be screening because people are living so long these days? Should people be getting colonoscopies after 75? I don't know. I'm not a GI doc, but this is kind of the rule of thumb. I would say 50 is probably the age that everyone should be getting their colonoscopy, maybe earlier, depending on how the new data comes out. Now, if you were to do this guy's colonoscopy, let's say hypothetically, this is what you see, this big, angry, inflamed mass that's nearly blocking his colon. Well, what would you do when you see that? Well, other than, a sigh of, disappointment and being sad for this gentleman, you're going to take a biopsy. So the endoscope, the colonoscope has a lot of tools on the end. Obviously you have a light, you have a camera, that's how we can see this picture, but then you have these other ports that can kind of poke out and you can put tools through. So you could spray water if you need to, you have suction, you could push through air. That's why we can get the image that we see here, because you push air into the colon to dilate it so you can look through that tube. And then of course you could take biopsies. You could take a little bite of something. You can get a snare. That's what this little polypectomy thing is, and kind of go around a small polyp and snip it off and then take it and send it off to pathology to look at. Okay, so a lot of different tools you could do with a colonoscope. In this situation, yeah, you would want to get a biopsy of that. And then we send that biopsy off to the pathologist. Maybe there's some budding pathologists on this call. They're going to look at it under a microscope. They're going to look at it and look at something like this and say, yeah, this is colon cancer. And then from that, they can tell you, kind of how concerning these cells are, So what do we do next? Well, for this gentleman, once we get from pathology that this is colon cancer, we have to do what's called staging. We got to figure out how far along this cancer is. So we'll do some other things. We'll get a blood count, especially if he's been bleeding. We want to make sure he's not anemic from his bleeding. You're going to get a CAT scan of his chest, his abdomen, and his pelvis to see if he has any metastatic disease, if this cancer has spread anywhere. You're going to get a CEA, carcinogenic embryonic antigen. Don't quote me on that one either. That's a tumor marker. So now it doesn't tell you how bad the cancer is, but it's a good marker to keep track of before and then after treatment to say whether or not this colon cancer is has it recurred or anything. Because ideally, it's probably elevated right now, and then after treatment, it will probably decrease. If it bumps up again, there's a concern that the cancer's back is kind of the thought. Depending on where this tumor is, you might need to get an MRI of his pelvis, especially if it's down in the distal sigmoid or the rectum. The CT it's good, but the MRI is a lot more detailed, and you could see almost the tissues that the tumor is invading if it's really bad. So let's say finally this guy's tumor status is T3N0M0. Well, T3 is the tumor size, N is the number of lymph nodes, and M is metastases. So he doesn't have any mets, he doesn't have any lymph nodes involved, and the tumor is T3, meaning how far has it invaded in the walls of the colon. That's kind of how you can tell. That snorting is my dog. Sorry about that. You okay, girl? She has allergies, I think. All right. So how do we treat colon cancer? Well, today in the United States, they do another minimally invasive procedure, a laparoscopic sigmoidectomy. So this guy's cancer was in his sigmoid. We go in with those tiny tools and we cut it out. The amount that we cut out is based on the blood supply. So here I put an image of the blood supply to the colon. Depending on where it is, you're going to cut and basically take that piece of colon. And then this patient will probably also get adjuvant chemotherapy, meaning chemotherapy afterwards, to kind of eradicate any other cancer that could potentially be still in his body. Here, let's say if we want to just take that sigmoid, you can kind of cut the artery right there and save the rest of that colon as well. And then you can kind of reattach the colon so that they can, have an intact colon. All right, so that was the last of the cases. So to wrap it up, we'll talk about what I think success in surgery. I think success in surgery is two things. One is success in the operating room. Are you skilled, knowledgeable enough to make decisions in the operating room, skilled enough to, do the procedure technically correctly, and then skills outside the operating room? Because they say, just as important in surgical residency, just as important as learning how to operate is learning when to operate, meaning not all patients need surgery, and when, as far as perioperative planning, because you have to make sure a patient is ready for surgery, and you have to plan for after surgery, how are you going to take care of complications or things like that, how are you going to take care of the patient. Now, the pros and cons of general surgery, I put some of my favorite TV surgeons on here. It's not quite like on TV, but obviously stereotypes exist in medicine because there's some truth to some of these people. But the gist of it that I tell folks is general surgery is life and death. It's really cool to save someone who is in that trauma bay and, about to die, or has really significant cancer and we cut it out and, then they're in remission. Conversely, we also, I would argue, deal with death a lot more than a lot of other specialties because we are in that realm of, treating patients with cancer significant enough that they necessitate surgery, treating patients in the trauma bay, things like that. Time, not just time during the day, like I showed you, where it's like could potentially be 14-hour days if you're, really in the thick of it, but also time as far as the years, because if you think about it, you did high school, you did college, you did medical school, then you could do a 7-year training program. That's basically what I'm doing. And then, another 2 years of fellowship after that. It's a lot of lifetime. So it's just something to consider, of course. Careers in surgery, there's so many different options, kind of like what I talked about previously. You could be anything from the rural community surgeon who does everything to the academic surgeon at a big institution where, you can get really honed in on your research and your surgery, and you're just doing one specific type of surgery for the rest of your career. And you're the top person in the country for that specific thing. So wide range of things you could end up doing. So with the last few minutes here, if there are any other questions, and then I also put my social media handles if you guys wanted to find me on any of my socials, and we'll take a look at some of the questions here. Okay. If there's anything you go back and change in your career path, what would it be that could help us all? Let's see. I guess I think, and I kind of alluded to this earlier, I would say when you get to medical school, be a little bit more open-minded about what you want to specialize in. I went to medical school to become a pediatrician. I kind of anchored on that until I was a third year in my surgery residency. And I realized, oh crap, I actually really like this. So kind of keep your mind open and think, you might, something that you can maybe never considered you would want to go into might be the career for you. Okay. And then within that career, or specialty, think about what you want to do with that specialty. And, there are a lot of options out there for you. So kind of keep an open mind with everything. Positive attitude for sure. Because, it's hard to go through medical school and go through residency and everything. But, if you are lucky enough to get to that point, then you're part of the select group that a lot of people would really, they would fight for that position that you have. So, think about that. Do you have any regrets being in this field? Do I have any regrets? Actually, no, not a one. I would pick general surgery a million times over. I absolutely love it. When I think about other specialties, I really respect the heck out of all of our colleagues that go and, when we consult different specialties and things like that. But I don't think that I would enjoy any other specialty as much as I enjoy general surgery. And they would probably say the same thing about me. They probably, they probably did their general surgery rotation in medical school and were like, oh yeah, this is terrible. I don't want to do this. But at the same time, I'm glad there are people in the medical field that want to do different things, because then it's like, I don't want to be a psychiatrist, but I'm glad that psychiatrists exist for my patients that need it, so that's kind of my perspective. No regrets. I'll pick surgery a million times. Have you worked with anyone as a DO in surgery? Yeah, all the time. If you are considering a DO school, that doesn't like preclude you from going into general surgery. There are a lot of general surgery DOs out there. Go to whatever you want to. Go to the school that's right for you. That's the number one thing I would recommend. And if it's a DO school, you could still go out there and be a surgeon. That's not going to stop you. Psychologically, how do you prepare patients for the possibility of needing surgery? Yeah, that's tough. So patients come with different expectations and different life experiences. Some of them have been, have family members who have undergone surgery all the time, or maybe they've undergone surgery themselves in the past, and they're super comfortable with the idea, and they're like, yeah, I want to get my surgery done because I want this hernia fixed or something like that. Then the other end of the spectrum is something like, the person who maybe is not familiar with it at all, never had surgery, doesn't know anybody who's had surgery, and they're scared. And that is scary. I think that's fair, because for those patients, they probably don't deal with surgery or medicine every day like we do. We're very not numb to it, but we're just comfortable with the idea of surgery because we've seen so many surgeries go well by the time that you're at this point in training. So I tell patients usually like, hey, I get it, you're scared, and that's totally fair because you don't see surgery every day like I do, but I can tell you that I'm working with Dr. So-and-so, and he's, that 60-year-old guy that walked by here, he's been doing this for, 40 years or something like that. Or, the anesthesiologist, yeah, this guy does this day in, day out. We do this day in, day out. This is like what we are comfortable with. And it's trying to kind of mitigate fears, answer questions while being sympathetic to their concerns. Sometimes it's more difficult than other times. But at the same time, in the United States, it's not like you can force anyone to do surgery. So in the United States, it's like we tell them what we want to do, how it's going to help them benefit their health. We tell them the risks and things like that could go wrong. And then they have to sign a consent to say that they want surgery. So I've had, several occasions where, patients don't want surgery, and that's totally their autonomy. That's totally their decision. You can only do so much to help someone, I guess, and explain to them how you can help them with whatever medical treatment it is. And if they refuse it, they refuse it. So I would say, as far as preparing patients, I just try and give them all the information that I can and let them make their own decision. Oftentimes, depending on how open you are with the patient, then you can usually, convince them to get whatever surgery that they need, as long as you're honest and respectful and explain things to them. That's what I found. So, and then keep in mind, it's 2021. I mean, they could Google it and find another surgeon down the road if they wanted to, if they don't like you. So, anyway, so I don't know if there are any more questions. I know it's top of the hour now. So, if there are any more questions, I don't know. Otherwise, thank you guys so much. What do you think?
That was the last one. Thank you so much, Dr. Gerardo, for presenting for our web shadowers and answering all of everyone's questions. It was really great to have you today. Everyone, please make sure you check out his social media. His Instagram and his TikTok are at dr.rod.md. The link to today's Google form has been posted in the chat box and will be in the description of this video shortly. Please make sure you fill it out within the next 30 minutes so we can receive verification of your attendance. That's all for today. Thanks, web shadowers. We'll see you next